Hello friends. Today we're going to discuss about treatment-resistant depression management. I'm Dr. Suresh Bharadwaj, Professor of Psychiatry, working at National Institute of Mental Health and Neurosciences, Bangalore. In this video, I'll be discussing about the assessment of treatment-resistant depression and also the management. I'll be discussing various aspects of management like switching strategy, augmentation, combining, psychotherapy, brain stimulation, and novel approach. Now let's understand treatment-resistant depression. The studies are very clear. Approximately 60% of the patient do not show symptom relief when we start first antidepressant. If you give even subsequent trial, that is second and third antidepressant, in spite of that, 30% of the patient do not respond to sequential trial of antidepressant. Only one third of the patient completely remit. Remaining, either they have partial response and another 30% completely resistant to medication. The studies have said that in spite of we have 25 different antidepressants approved by FDA, 30% of the patient do not show any improvement. If you start the first antidepressant, the improvement will be only 36%. If you start the next second antidepressant, switching over you do, another 30% will improve. For the third antidepressant, another 13, and fourth antidepressant, 13. That means one third of the patient are completely resistant for treatment. If you look at the impact of treatment resistance, the treatment resistance has a direct impact on mortality and morbidity. Mortality in the form of suicide, morbidity in the form of occupational dysfunction, academic decline, poor family functioning, marital discord. Invariably, they resign from the job. And this treatment resistance has a high impact in terms of economic, visiting hospitals, inpatient admission, non-productive. So it has an economical burden not only on the patient, on the family, on the community, and nation at large. So treatment resistance has a direct bearing on the economy of a nation. Now let's define what is treatment resistance. Various studies, systematic reviews, and meta-analysis have clearly said that there is no consensus with regard to the definition of treatment resistance. Hence, Group of Study of Resistant Depression, that is GSRD, came up with the definition. The definition was very clear. 2 failed trial of antidepressant, either switching or in combination or in augmentation. And there should not be any improvement and leading to dysfunction in the patient. Another study by that is Canadian Expert Consensus Guideline, which talked about the definition of antidepressant, published in 2020 in Depression Anxiety Journal by Ryback and his colleagues. This experts consensus guideline or expert consensus Canadian guideline said that 3 important criteria. One is there should be 2 antidepressants have been failed. Failed to improve means the improvement should not be more than 50%, and the dosage duration should be at least 4 to 6 weeks. Then only it will be considered as adequate trial and failure for treatment, and it has to be 2 antidepressants. If you look at the factors contributing for treatment-resistant depression, the Canadian expert guideline again came up with various factors, and those factors which are very high in prediction were symptom severity and frequent episodes, longer duration of illness, and the moderate predictors were longer duration of illness, psychosocial stressor, number of episodes in the past, bipolarity, current psychosocial stressors, comorbid anxiety disorder, substance use, personality disorders, comorbid medical illness, treatment factors like not responding to treatment earlier, failed psychotherapy trial, and these are the various factors have been found. And these factors you should know. Then only you'll be able to say, yes, this patient will respond or not, and you have to be aggressive in treatment, and you need to engage the family. Before we define treatment resistance, you should know about pseudo resistance. What do you mean by pseudo resistance? Many a time the patient may not take the medication regularly. That means poor adherence, poor dosage, duration may be very less, and many a time, along with depression, they may have fibromyalgia, obstructive sleep apnea, bipolar depression, neurological illness, and that time you may mistake them for severe depression, or you may consider other medication. And many a time, you may miss the comorbid diagnosis, like there may be OCD, eating disorder, or maybe endocrinological disorder. And you may think that the patient is resistant for depression, but it will be other illness. Further, you need to know whether it is a relapse or recurring, or else it is a true resistance. Many a time patients may be a rapid metabolizer and they may not respond. So these are the things you should know. Now let's enter into the assessment of treatment-resistant depression. If you look at the assessment, we need to do a detailed evaluation whenever you suspect treatment resistance. You need to take a thorough family history, look for the interpersonal stressors, marital discord, interpersonal issues, economic stressors, occupational stressor, past history of non-response to treatment, past history of episode. If the treatment history is documented, please look into the various prescription. What was the dosage? Any side effects? Look for psychiatric comorbidity, medical comorbidity, optimize the dosage of medication. Whether check for the patient who is taking medication regularly, that is, whether supervised medication was there or the patient was taking by himself. Many a time you have to do a structured assessment for the response. So that structured assessment can be of various scales. It can be Hamilton Depression Rating Scale, Madras, or it can be CGI Improvement, Severity Rating Scale, or Improvement Scale. The which is available publicly is CGI, and in practicality, it is very easy to use it, and it is freely available. CGI Improvement and Severity Rating Scale, please use that so that you will come to know how much the patient is improving. But for to look into the psychiatric comorbidity, either you may have to use Mini or SKID. Both are paid versions. Unfortunately, in private practice or even in the busy OPD, it is very difficult to use. You may have to rely on WHO's FLY, which is about to be released, which will be free. And for the treatment resistance, you may have to use Dutch measure for quantification of treatment resistant in depression. However, Madras and CGI can also be used. But please remember, these are all for academic and research purpose. In busy psychiatric OPD or in private practice, it's simply impossible to use this because it will take 2 to 3 hours. So if you have that luxury of time, then you can use these scales. Otherwise, it's more of academic interest and discussion with regard to assessment and doing research. Now let's look into the management of treatment-resistant depression. As I mentioned earlier, more than 25 different medications have been approved by FDA. At the same time, especially in countries like India and other Southeast Asian countries, off-label other drugs can also be used for treatment of depression. That is the luxury we have. And we need to have the objective for treatment of treatment-resistant depression. What is the objective? Objective is to prevent relapse, decrease the severity, make them functional. That should be the pragmatic approach of treatment-resistant depression. Now let's look into the algorithm which has been given by various studies. If there is a treatment-resistant depression has been diagnosed, then you have to do some clinical assessment and lab investigation. The clinical assessment has to look into the various environmental factors and patient factors. Look whether there are any severe stressor, any personality disorder, any psychiatric comorbidity is there, or medical comorbidity is there, and you need to identify them and address them. But at the same time, you have to do certain lab investigations like hemogram, vitamin B12 folate deficiency has to be checked, vitamin D, thyroid function test, LFT, RFT electrolytes, urine for drugs, and inflammatory index. As I mentioned in the earlier my videos, neuroinflammation has been considered as a important indicator for non-response for treatment. And if you suspect endocrinological uh, dysfunction, you may have to give endocrinology referral. Now, I'll be discussing very important study. This is done by Roberto and his colleagues, published in 2020 in a journal called as Pharmaceuticals. The title of the study is Pharmacological Treatment for Patient with Treatment-Resistant Depression. I request all viewers to go through this study. This study has been beautifully written and a thorough evidence-based research has been done. Let's look at the strategies of treatment-resistant depression. Here, it is a combination of various guidelines I'm using. The guidelines I'm taking from treatment of depression and also treatment of treatment-resistant depression. That means I'm combining this and giving this video. Please remember, it is not specifically from treatment-resistant depression guidelines. The guidelines are very few if you ask me. There are only 2 guidelines across the world which has incorporated treatment-resistant depression recommendation. Otherwise, many of the guidelines have said that yes, if the first drug fails, what to be done? Second drug has to be failed, what to be done? Those strategies I'm going to use here, which can be applied even in treatment-resistant depression. The strategies can be switching, augmenting, combining, psychotherapy, neuromodulation, ketamine, and novel treatment. Now let's discuss when to switch, when to augment, when to combine. First and the foremost, switching. If there is no improvement at all, or the improvement is less than 25%, please consider switching. That means switching from one antidepressant to another antidepressant. So which antidepressant has to be chosen? Of course, you will be choosing from a different class of antidepressant. Again, which antidepressant in the different class? This is based upon comorbidity, symptom profile, symptom severity, access to treatment, affordability for treatment, and treatment preference. That means there is no straightforward answer. You need to consider various factors. For example, if the patient has medical illness, hypertension, diabetes, you may have to choose a safer medicine like escitalopram. If the patient symptom severity is very severe like catatonia, lorazepam and ECT have to choose. If the patient is suicidal, you will be choosing ECT. And imagine if the patient has different symptom profile. If the patient is agitated, restless, you'll be choosing a medication like mirtazapine to calm him down. Imagine the patient is retarded. You'll be choosing an SSRI. So even the symptom profile play a major role. Access to the treatment. Imagine if you say if the patient requires vagus nerve stimulation, it is not available in your country or in the area, and the patient is not affordable at all. So all these has to be considered before you recommend for switching. Again, in switching, the strategy used is either cross tapering, that is decreasing the medication which has not helped and increasing the new medicine. Another one is washout period, stop the medication, wait for the washout period, and then start the new medicine. The third one is abrupt stopping the old medicine, starting the new medicine. But however, keep in mind, half-life of the previous medication which has not helped will be dictating how you are going to start. But the dictum is start low dosage, go slow. This has to be followed. At the same time, whenever you are switching, please consider the half-life of both the medication. What is the drug interaction? Think about cheese reaction. If you are going to start monoamino oxidase, that is tyramine related foods, and monoamino oxidase causes hypertensive crisis. Or else monoamino oxidase, and if you are combining with tricyclic antidepressant or any SSRIs, they may trigger cheese reaction. Many a time, serotonergic syndrome is also one of the threat you have to keep in mind. And finally, if you are giving venlafaxine, withdrawal symptoms also has to be considered. These are the various switching agents can be considered from one class to another. First one is an SSRI, like citalopram, sertraline can be considered. SSRI plus, here 5-HT receptors will be considered, and it is considered as a 5-HT modulator also. Here valtoxitin is the drug. SNRI, venlafaxine, and desvenlafaxine, TCA, imipramine, amitriptyline, nortriptyline can be considered. Monoamino oxidase, moclobamide is one of the commonest. Atypical is bupropion, and glutamate is esketamine and ketamine. These are the switching agents can be considered. These are the various studies which have been done for various antidepressant classes. When you are switching from SSRI to TCA, the studies have clearly said that the improvement is seen up to 44 to 73%. This is very encouraging. Similarly, if you are switching from TCA to monoaminomoclomide, that is MAO inhibitors, there again the 60% improvement is there. Hence, if there is no improvement, less than 25% improvement, switching strategy is the best, and the chosen should be from different class of drug. And choose the cross-tapering method, keep an eye on the drug interaction, cheese reaction, cetonergic syndrome, and the dictum is start low, go slow. Now let's move into the augmentation. When will you choose augmentation? Augmentation will be chosen when the patient improvement is more than 25%. That means you do not want to shift the medicine which has helped him. Here you will add another medicine which will be an augmenting agent. Augmenting agent invariably are called when these medicines are given alone will not have any effect independently, but it has to combine with another antidepressant. For example, mood stabilizer, lithium. When lithium is given alone for depression directly may not be helpful. So you have to combine with an antidepressant. Similarly, for depression, second generation antipsychotics plus antidepressant will work. Thyroid, T3 and T4, anticonvulsants, lamotrigine, valproate can be considered. Another one is bupropion. Let's look into augmentation with atypical antipsychotics. There are many studies which have been done, and they have equivocally said that for treatment-resistant depression, aripiprazole, brexpiprazole, cariprazine, olanzapine, risperidone, and quetiapine has been found to be helpful. But you have to be very careful about the side effects, such as weight gain, metabolic syndrome, dysfunction, and tardive dyskinesia. Hence, give these atypical antipsychotics in the acute severe depression phase only. Later, when the patient response improves, you may have to discuss with the patient and the patient family, and you may have to withdraw the atypical antipsychotics. So the risk versus withdrawal and having a relapse versus having a side effect. If you look at the CANMED guidelines and American Psychiatric Association guidelines, both choose atypical antipsychotic as the first line of augmentation. But however, there are other augmenting agents like mood stabilizers, combination of other antidepressants, use of stimulants, thyroid hormones, and ketamine has been considered. If you look at the number of studies with regard to second generation antipsychotics or atypical antipsychotics, there are many. Other agents which can be considered as thyroid hormone, that is T3 and T4, and lithium, use of stimulants, and ketamine. If you look at the thyroxine studies, both T3 and T4 are used, but there are a number of studies which said T3 is more effective than T4. Hence, choose T3. T3 has to be given in the dosage of 25 to 50 micrograms. It has to be given at least 2 months to say, yes, it has adequately improved or not. That is the adequate trial. And it has to be given along with in the early morning again, in the dosage of 25 to 50 microgram, and it is as effective as lithium. The studies have said that T3 has not been used properly and it has been underutilized, even in Western country and also Eastern countries. If you look at the lithium studies, again, the number of lithium studies in treatment-resistant depression also is more. The dosage is between 300 to 600 milligram. Although lithium is not an FDA-approved drug for treatment-resistant depression. Lithium monotherapy may not be helpful, but there are in open label trial, yes, lithium has been found to be effective in depression, but in treatment-resistant depression, the data is very few. And again, if you look at the data, they say lithium is as equivalent effective as second generation antipsychotics. Now, let's move on to lamotrigine. Again, if you look at the lamotrigine, it is not FDA approved and the studies are inconclusive. However, the studies with regard to bipolar depression, lamotrigine has found to be useful. But in unipolar depression, treatment resistance, it is not much of useful. There was an interesting study done by Nunes and his colleagues published in Journal of Affective Disorder in 2022. They looked into various augmenting agent and they did a network meta-analysis. This network meta-analysis included 65 studies comprising 12,415 patients and looked about 19 augmenting agents, not one or two, 19 augmentation agents were studied. The agents which showed response, good response, that is between more than 50% improvement were seen. They were T3, nortriptyline, aripiprazole, bexiprazole, quetiapine, lithium, modafinil, olanzapine, and cariprazine. At the same time, the network meta-analysis also looked into which are those medicines which caused remission, complete improvement. Again, T3, aripiprazole, brexiprazole, risperidone, quetiapine, and olanzapine plus fluoxetine combination. So, my dear friends, the augmentation agents have been very clear. They should be used. To summarize, atypical antipsychotic stands first. At the same time, lithium and T3 should be used appropriately since they have been underutilized. And for the purpose of improvement, it has to be more than 50%. And give at least a period of 6 weeks as an adequate duration. And for augmentation purpose, 50% of the total dosage can be given. That means especially lithium in the dosage of 600 to 300 will be given. Now let's discuss about combining two antidepressants. Again, in this area, the literature are very sparse. The main reason is combining two antidepressants can cause some of the serious side effects. Combining monoamino oxidase, MAO, with SSRI or TCA can cause chase reaction. TCA with an SSRI also can cause some of the serotonergic syndrome. And again, two SSRIs, serotonergic syndrome. So you have to be very clear when we are combining. Hence, you need to keep drug interaction in mind, hypertensive crisis, serotonergic syndrome. Invariably, half-life of the medications should be known and drug interaction has to be known when we are combining two antidepressants. If the illness is very severe, you can think of combining two antidepressants of two different classes. You need to weigh the risk versus benefit. However, at this point of time, studies are very sparse with regard to combining of two medication because of the potential side effects. Now let's move into the brain stimulation. The brain stimulation strategies are ECT, transcranial magnetic stimulation, direct brain stimulation, transcranial direct current stimulation, and alternative current stimulation. At this point of time, FDA has approved only ECT, RTMS, and vagus nerve stimulation. TDCS has not been approved. But however, remember, none of the above strategies are given as a standalone treatment. You need to combine with an antidepressant. For example, you cannot give ECT alone and expect there will be no relapse or else recurrence. You have to give an antidepressant. That means ECT will be given for an acute treatment. For maintenance and prophylaxis, you have to give antidepressant. For even RTMS, similarly, you will give transcranial magnetic stimulation in acute phase of treatment. For maintenance and prophylaxis, you will continue antidepressant. That means it is a combination strategy. Let's look into the ECT. ECT is one of the effective treatment and it is used 3 sessions per week. And invariably, 8 to 15 sessions are considered as an adequate trial. If you look at the consortium of research in ECT, the studies have found that in treatment-resistant depression, more than 50% of the patient improved. Not improved, actually they recovered. That means ECT is found to be very, very effective. Even other studies have also said that 50% of the patient had improved who had failed to respond for antidepressants. Please remember, ECT has to be given along with a mood stabilizer. It cannot be a standalone treatment because of the high risk of relapse or recurrence, and you need to give prophylaxis. At this point of time, ECT remains as one of the effective treatment, but unfortunately because of stigma, not only by the public and even our own medical fraternity, says that ECT is a dangerous treatment. But at this point of time, it is the very safest, very quickest way of getting rid of depression. Now let's move into RTMS. that is transcranial magnetic stimulation. FDA has approved this. The sessions has to be given 20 to 30 sessions on everyday basis. 10 hertz at the left dorsoprefrontal cortex is the chosen one. However, the current evidence also indicates towards low frequency RTMS in the right dorsoprefrontal cortex and bilateral also can be considered. At least 3 large multi-site trials in adults have found that patients who have not responded to 4 antidepressant showed improvement in RTMS. That means it has found to be very helpful. Again, if you look at the head-to-head comparison with ECT, for the acute period, RTMS has been found to be helpful. That means it is almost equivalent to ECT. That's what some studies says. There is no significant difference between RTMS and ECT. If you look at the RTMS has more of advantages in terms of no need of anesthesia. No, there is no side effect of anesthesia. You need not prepare the patient. You need not admit the patient. You can give RTMS on OPD basis. And again, the memory loss will be very less in RTMS. But effect lasts very short period in RTMS, whereas ECT has a longer effect. But at the same time, both RTMS and ECT requires antidepressant concurrently has to be given. RTMS has been found to be helpful in children, adolescent, pregnant women, and geriatric patients because of the side effect profile. Now let's move into deep brain stimulation in treatment-resistant depression. Reddy and colleagues did a study on deep brain stimulation in treatment-resistant depression and did then meta-analysis. This meta-analysis consisted of 7 RCTs, which consisted of 198 patients and 8 open-label trial of 77. Totally, 275 patients were studied. Again, DBS was found, 47% improvement was noted. Again, but the improvement did not occur immediately. Improvement occurred over a cumulative period of 23 months. So my dear friends, once you do DBS, don't say that they will improve in next month. The improvement occurs over a period of 2 years. So deep brain stimulation causes chronic slow improvement. But however, we need to do a lot of studies. RCTs has to be conducted. We need to know the parameters, how to stimulate, where are the stimulars, has to be done, and we have to see the effect of comorbidity on deep brain stimulation. Now let's look into the TDCS, transcranial direct current stimulation. Again, there are no major studies. The recent one of the poster presented looked into 4 clinical trials comprising of 967 patients who are treatment resistant received TDCS. Anode was placed on F3 and cathode was placed on F4 of 1020 international EEG standards. And again, here the current was given in a ramp up phase of 5 to 30 seconds followed by 30 minutes of 2 milliampere and ramped down 15 to 30 seconds. Treatment frequencies varies from twice daily to 3 times per week and also 5 days to 20 days. 10 of the 14 studies showed improvement. But however, TDCS has not been approved by FDA for treatment-resistant depression. Now let's move into psychotherapy. Psychotherapy, again, a recent Cochrane review published in 2018 examined 6 studies where RCTs specifically for treatment-resistant depression. The psychotherapy considered were CBT, DBT, interpersonal therapy, and finally short-term psychotherapy. Cochrane results indicated wherever CBT was added along with the antidepressant, it was found to be very helpful. And improvement lasted for 2 to 4 years. So psychotherapy along with medication has found to be helpful. Simple reason is these are all treatment-resistant depression, severely ill cases. You cannot do psychotherapy alone. In severe cases, we have to give medications first and try to see improvement, and then you have to do psychotherapy. Hence, psychotherapy and medication have been found to be helpful. That was the Cochrane Review's results. Another study by Lee and his colleagues, published in 2018, did a meta-analysis of 6 clinical trials, which included 924 patients, invariably CBT. Again, the CBT in standalone For treatment-resistant depression, they found that many patients improved. Both the improvement sustained over a period of 6 months to 12 months. But however, this study was criticized by the own authors with regard to the quality of the study. Again, in 2020, Gloucester and colleagues did a meta-analysis of 18 randomized control trial comprising of 1,734 patients with regard to psychotherapy. Majority of them were CBT, psychodynamic were 2, mindfulness were 5, and interpersonal therapy was 1. The meta-analysis again said that positive effect of psychotherapy was seen in treatment-resistant depression when it was given standalone. But however, at this point of time, there is no sufficient evidence to say which psychotherapy has to be chosen, whether it is CBT, whether it is IPT, whether it is psychodynamic, and which therapy has to be chosen. If the patient did not improve with one psychotherapy, the next which should be chosen. What should be the number of session? Imagine, can we increase the number of session? Can we give around 70 sessions? How long the sessions has to be given? When we can call them as a treatment failure? Should we admit them inpatient and do a acute residential monitored therapy? So they are not clear at this point of time. Further, digital applications based psychotherapy, are they helpful? Again, there are few studies, but RCTs has to be done with regard to treatment-resistant depression. But at this point of time, my dear friends, what is known and advocated is combination of psychotherapy plus medication is the best. Now let's discuss about ketamine and esketamine. Both are NMDA receptor antagonists. A study done by Chernik and his colleagues published in Frontier in 2024, which looked into the ketamine in treatment-resistant depression. If you look at the treatment of ketamine, it can be given in various modes, either IV, intramuscular, subcutaneous, intranasal, sublingual, and oral. Oral is the least bioavailability. Highest is intravenous. That means we have to choose one of them. Invariably, the commonest studies are IV, intranasal, and sublingual. If you look at the intravenous, the dosage is 0.5 milligram per kg body weight. Intranasal is 1 milligram per kg body weight. Sublingual is 1.5. And if you look at the maximum effective dosage is double the minimum effective dosage. So my dear friends, intravenous requires admission. Intranasal can be given on OPD basis and sublingual can be taken at home, but it requires to be monitored. If you look at the results of this review, they have said that ketamine has been found to be very useful in treatment-resistant depression. IV, intranasal and sublingual are the most commonly studied route of administration of ketamine. Another interesting study, a meta-analysis done by Al-Nifsi and his colleagues in 2022, published in Journal of Psychiatric Research. The title of the study is Real World Difference with regard to effectiveness of ketamine in treatment-resistant depression. This meta-analysis included 79 studies comprising of 2,665 patients. They looked into the immediate effect and mid and long-term effect of ketamine, whether it continues to sustain the improvement of treatment-resistant depression. The present study confirms that ketamine is effective overall, and it is also effectiveness varies considerably across population. That's what the study said. If you look at the ketamine and esketamine studies, there are a number of studies which are available. But again, treatment-resistant depression studies are very few. Another study done by Lee and his colleagues published in Neuropsychiatric Disease and Treatment Journal, and the title of the study is Efficacy and Safety of Esketamine Combined with Antidepressant, a Meta-Analysis. This meta-analysis included 7 articles combining of 701 patients. Here esketamine and antidepressant were considered and it was compared with the 551 placebo group. And again, esketamine and antidepressant were found to be very effective and remove depression very quickly. However, the authors have said that what will be the long-term effect, we do not know. Whether there will be relapse, should we again give esketamine and antidepressant is the question. If you are giving nasal spray of esketamine, the single induction dosage will be 56 milligram on the day, and it has to be continued for next 1 month. Every week or twice a week, 56 to 84 milligram intranasal has to be given. And next 1 month, you have to give weekly once, 56 to 84 milligram per week has to be given. Now let's move into the novel treatment. The novel treatment are those treatment or therapeutic treatment which are new, innovative, and has not been used as a standard medical treatment. It often involves new technology, methods, or drugs that have been developed and recently been tested. The two commonest can be considered as vagus nerve stimulation and psychedelics. Psychedelics are those drugs which are considered as mind manifesting. The Greek word psychedelics means, or mind wandering, you can call it as. If you define psychedelics, these are those compounds which produces various psychological effects characterized by altered state of perception, thoughts, feelings, and consciousness. And at present, there is no consensus which are those drugs which are psychedelics, which are not. However, there is a classification of psychedelics. One is classic serotonergic psychedelics, which acts through serotonin 5-HT2A agonism. The second one is atypical psychedelics. They do not act through serotonergic. Simple. These are the two classifications. The proposed mechanism of psychedelics are synaptic plasticity, functional connectivity, and cognitive flexibility. These are the various ways psychedelics have been found to be helpful. If you look at the classic serotonergic psychedelics, psilocybin, ayahuasca, ergolines like LSD and LSA, and phenethylamine are being considered, that is mescaline. If you look at the atypical psychedelics, MDMA, ketamine, mescamol, salvinorin, ibogaine, and norbogaine has been considered as the atypical psychedelics. The commonly studied and explored at this point of time with regard to treatment-resistant depressions are psilocybin, ayahuasca, or you can call it as DMT, and ketamine. With regard to psilocybin, the first multi-centered, multinational study, which were randomized, recruiting 233 patients, done by Goodwin and his colleagues. Here, they were randomized to 25 milligram, 10 milligram, and 1 milligram of psilocybin. The patients who received 25 milligram of psilocybin showed a significant improvement with regard to treatment-resistant depression. And this is one of the robust study, but however, this study was sponsored by pharmaceutical industry, hence there is a criticism with regard to this. However, when you are giving psychedelics, you need to withdraw the antidepressant for a period and then you are giving the psychedelics, and after that again you have to restart the antidepressant. That means invariably in conjunction you will be giving with antidepressant. And nowadays, psychedelics with psychotherapy has been found to be very effective. Invariably, this was given in 1960s and 1970. Their time it was considered as psychedelic psychotherapy. Now, it has been reintroduced. So, invariably, dosing of these psychedelics should be given once or twice a month or twice a week. That needs to be explored. Some of them have been told once a month or twice a month has also been told. Invariably, psychedelics effect lasts from 2 to 6 months. But still, there are a lot of unanswered questions with regard to psychedelics, especially in treatment-resistant depression. Whether the combination of psychotherapy, which is helping, is it psychotherapy or is it psychedelics? Is it concomitant antidepressant is given, which gives a longer-term effect? If psychedelics is given, will it have a complete cure of depression? No, definitely it's not there. But still, you need to answer how much psychedelics is going to change the brain. Further, what is the long-term effect of psychedelics and whether it causes addiction? These are the things we should know. The last one we'll be discussing about vagus nerve stimulation. Again, this has been approved by FDA for treatment-resistant depression. In this diagram, you can see that there is a pulse generator, or else also called as a stimulator, along with the lead and a clamp which is going to be connected to vagus nerve stimulation. Here you can see in the subclavian fossa, the pulse generator is kept. From there, the lead or the electrode goes and clamps to the left vagal nerve stimulation. Invariably, the commonest is left vagal nerve stimulation. The right vagal nerve stimulation is not been chosen. The reason being, the left vagal nerve stimulation directly connects to the atrioventricular, the right will connect to the atrioventricular node, whereas vagus nerve stimulation with left connects to the SAN. So that means if you connect to the right, there is a possibility of atrioventricular block can occur, conduction difficulties can occur. Hence, left vagal nerve stimulation is taken. Here the pulse generator stimulates the left vagal nerve stimulation. So that in terms causes mood regulation. These are the various open label trial with regard to vagus nerve stimulation, and it has been found to be very useful. The FDA has given approval for both unipolar and bipolar depression and for treatment-resistant depression in both. So vagus nerve stimulation is very costly, has its own side effects, and affordability is a big problem, and accessibility of this treatment is also a problem. That means only in big centers and metropolitan cities it is available, and it is not being used, it is being given by insurance companies in India, but in US it has been considered. Now let's move into psychostimulants. There are various psychostimulants like modafinil, methylphenidate, and various other drugs like fenfluramine has been considered, but the treatment results with regard to treatment-resistant depression, the results are inconclusive. To conclude, my dear friends, treatment-resistant depression has a severe impact on the patient, family, and the nation at large. It has a direct bearing on the economy of the country. Unfortunately, there is a lack of consensus with regard to the definition of treatment-resistant depression. We need to come to a conclusion that, or a agreement, there is a treatment-resistant depression, that is, 2 antidepressant has failed. Hence, we have to consider this as a treatment-resistant depression so that we can do research and it can be comparable. Now, for the treatment-resistant depression, ECT, ketamine, psilocybin, esketamine has been found to be very helpful and effective. With regard to augmentation, second generation antipsychotics, lithium, T3, lamotrigine is query, combining with other antidepressant, bupropion, TCAs have been found to be very useful in treatment-resistant depression. However, neuromodulation, ECT, and RTMS can be considered. DBS, again, is in the exploration study. But however, my dear friends, psychedelics, especially psilocybin, ECT, and second generation antipsychotics have to be used judiciously after discussing with the patient. Thank you very much for giving your valuable time. Stay safe.